My name is Brittany Accavello, and I'll be discussing Prader-Willi syndrome in this presentation. Prader-Willi syndrome was first identified in 1956 by doctors Prader, Labhart, and Willi. The initial discovery came when this group of doctors examined a group of young children all exhibiting phenotypic characteristics that appeared syndrome-like in nature. Doctors began recording their findings, but little was known about Prader-Willi until a new discovery was made by Dr. David Ledbetter in 1981, linking a deletion on chromosome 15 to the disorder. Prader-Willi is a rare genetic syndrome that affects approximately 1 in 15,000 live births. It affects all races equally and men and women equally. Although Prader-Willi is considered rare, it is the most common cause of genetic obesity and is one of the 10th most commonly seen genetic syndromes in genetic clinics. Although Prader-Willi is a spectrum disorder, meaning individuals exhibit varying degrees of severity, there are common phenotypic characteristics shared by almost all. During the prenatal period, babies with Prader-Willi are within normal limits for weight and BMI, but are typically 15% smaller than their normal siblings. Although weight is normal, the baby is severely hypotonic in utero, meaning mothers usually report lower than average fetal movement throughout the pregnancy. Since the baby is with such low tone, it is common for the baby to present with abnormal positioning at delivery, often needing assistance via vacuum, forceps, and ultimately a C-section is usually indicated for these women due to poor progression of labor. After birth, these babies almost always present with continued poor tone and decreased movement. They are less vigorous than normal and are commonly lethargic and sleep through care times. When they are aroused, they have weak cries, poor reflexes, and ultimately are poor feeders, which usually progresses to failure to thrive if left untreated. Due to low serum gonadotropin levels, both male and female babies exhibit signs of hypogonadism. During childhood, muscle tone does improve but always remains mildly hypotonic into adulthood. There continues to be delayed motor, language, and overall milestone achievement. Intellectual impairment becomes apparent around preschool, although differing in severity, with most impairment falling around mildly impaired with low normal intelligence and an estimated 20% having severe delays. Although feeding issues are present in infancy, by the time the child is of preschool age, hyperphagia becomes the primary concern and is perhaps the most concerning and well-known characteristic of Prader-Willi. The child begins to have insatiable hunger due to hypothalamic abnormalities and increased ghrelin levels. This, paired with a low metabolic rate and energy expenditure, causes extreme obesity if not externally monitored by caretakers. Behavioral issues start to unfold, commonly related to hyperphagia, with food-seeking and hoarding behaviors, temper tantrums, stubbornness, manipulative behaviors, and even stealing food or stealing money to buy food. These findings continue into adulthood with additional mental illnesses like OCD, ADHD, depression, and sometimes psychosis. Adults are usually infertile, have sleep disturbances, spinal and bone issues, progressing obesity and related issues, and in rare cases, experience seizures. A closer look at the characteristic facial features of Prader-Willi include almond-shaped eyes with palpable fissures, narrowing of the temples, narrow nasal bridge, and thin upper lip with a downturned mouth. They commonly have hypopigmentation of the hair, skin, and eyes, and often are of fairer complexion than their normal siblings, depending on subtype. In examining the genetic characteristics of Prader-Willi, scientists do not yet know exactly how many genes are involved or which specific genes are involved. They do, however, know the region affected is 15q11 to q13, which contains genes critical to Prader-Willi, and that more than one gene is involved, and those genes are located on the long arm of chromosome 15. Since we know that the mother's genes are turned off in this particular area due to genomic imprinting, the critical genes must come from the baby's father in order to function properly. We know that Prader-Willi syndrome is not typically inherited, but most commonly happens de novo, with a reoccurrence risk in subsequent pregnancies of less than 1%. Prader-Willi can be the result of 3 different types of errors. In all 3 types, Prader-Willi is the result of the proband failing to receive activated genes from the Prader-Willi critical region of the proband's father's DNA. The first is pattern deletion, accounting for 70% of all Prader-Willi syndrome cases, making it the most common form of Prader-Willi. In this form, part of chromosome 15 is inherited from the child's father containing Prader-Willi critical genes, which is missing. Typically, the deletion is from an unknown reason and is not likely to happen again in future pregnancies. In instances of microdeletions or translocation as cause of defective or lost Prader-Willi critical genes, it is possible that the family could have another child with Prader-Willi syndrome as well, and these families should be encouraged to seek genetic counseling. Maternal uniparental disomy, or UPD, accounts for 25% of all Prader-Willi cases. The baby inherits both copies of chromosome 15 from the mother. The developing fetus typically starts off with trisomy 15 due to an extra chromosome 15 in the mother's egg. Later on, 1/3 of the extra chromosomes is lost, the one from the father's sperm. The result is the same as deletion, where the active genes that must come from the dad in order to function correctly and be expressed are missing. In this type of Prader-Willi syndrome, the older the mother is, the greater the likelihood of this happening, since older eggs are more commonly have extra chromosomes. Here's where it gets a little more complicated. The baby can either one of each of the mother's own chromosomes or 2 identical chromosomes from the mother. Only in instances where the baby inherits 2 identical chromosomes is the chance of future offspring having complications as well, aside from the factor of having older eggs. Lastly, imprinting defect, which is prevalent in less than 5% of cases. In these rare instances, the Prader-Willi critical genes are present in the father's genes but do not work due to a faulty imprinting process. The error in the imprinting control center can be a new development, or he could already have it in his chromosomes inherited from his mother. If he did inherit it from his mother, he wouldn't have Prader-Willi syndrome himself since it's on his maternal chromosome 15, but he could pass it on since it would then be on his baby's paternal chromosome. When this is the cause, there is a 50-50 chance the father could pass along to any and all offspring, which makes genetic counseling extremely important in these instances, as well as the father's siblings should be aware that they could be affected as well. Prader-Willi syndrome and Angelman syndrome are often referred to as sister syndromes. The disorders do not share many common characteristics. However, those with Angelman syndrome also have a deletion of chromosome 15 Q11 through Q13. The difference is that those with Angelman syndrome lack the gene from their mother instead of from their father. Prenatal testing is available if suspected, which can provide reassurance to a family who may already have a child with Prader-Willi syndrome. Although, as discussed, the baby would have a very low risk of also having Prader-Willi syndrome. This can be done via chorionic villus sampling or amniocentesis. Once the baby is born, and if he or she is suspected of having Prader-Willi syndrome, there are additional tests that can be ordered to diagnose Prader-Willi syndrome. These include high-resolution chromosomal analysis, FISH testing, DNA methylation tests, and DNA polymorphism studies. Typically, if Prader-Willi syndrome is suspected, you would start with chromosomal analysis and continue on from there as needed. This is valuable for the advanced practice RN, as he or she would need to know the signs and symptoms of Prader-Willi and order the appropriate testing if suspected. Due to the complexity of Prader-Willi syndrome, oftentimes multiple tests are needed to determine a diagnosis and distinguish between the different genetic components. For the sake of time, I won't delve into the differences of these tests, but rather I'll just leave this here for those interested. Treatment and management of Prader-Willi varies widely given the spectrum of the disorder. Since feeding issues are typical in infancy, families should be educated on specialty nibbles and even feeding tube use. As the child gets older, the family would need to be taught how to strictly monitor food intake and assure a well-balanced diet, as well as being educated on dealing with potential behavioral problems to come. Parents should know how to administer medications to help manage the disease, such as growth hormone therapy has been shown to improve musculature, decrease chances of obesity, reduce behavioral difficulties, improve speech and reasoning skills, decrease sleep disturbances, and should be started at infancy. In addition, specialty consults are necessary, such as behavioral therapy, orthopedic evaluation, physical therapy, endocrinology for sex hormone replacement therapy, and other hormone complications, as well as additional medications like SRIs for OCD, mood, mental illness, and supplements for bone and muscle growth. An up-and-coming experimental treatment that could be available in the future is transcranial direct current stimulation, or TDCS, to reduce hyperphagia has been shown to largely decrease food cravings for diet management. These are all important for the APRN to be aware of, as well as educate the families on. As for prognosis, due to the spectrum of possibilities, IQ can range from low to severe delay. Most individuals end up in group homes specialized in treatment of Prader-Willi management. In a small number of cases, patients have been able to graduate from college and live on their own with guidance. Prader-Willi involves some ethical considerations. The major consideration includes strictly monitoring dietary intake of the child into adulthood. These patients feel constant hunger, so although limiting their intake is most beneficial for them, It can be a difficult burden to place on parents and family members to take away food from a child who feels as though they are starving. In addition to obesity management, there are ethical concerns when discussing the amount of medication a person will be on for the entirety of their lives. As I mentioned prior, TDCS as a future treatment raises questions and concerns given the nature using electrical currents as therapy. Genetic counseling alone is often a hot topic for ethical debates, especially if parents choose to electively terminate a pregnancy affected with Prader-Willi syndrome. Caregiver burden is a concern, since caring for these individuals takes constant monitoring, and often group homes are what is best for the adult with Prader-Willi, although family members often feel guilt. Lastly, the financial burden of this disease is vast, with the involvement of so many specialties, cost of food, caregiver programs, and long-term living. Thanks for listening.